So type 1 diabetes poses a unique burden. It is an interplay of adjusting complex insulin regimens, behavior and social modifications, and need of considerable knowledge and skills so that the patient can navigate between hypo and hyperglycemia safely. Next slide, please. What are the symptoms of type 1 diabetes? When does a patient of type 1 diabetes walk to your center? Either it is with a high blood sugar report, which they accidentally discovered during the routine investigations by their pediatricians because of weight loss or other symptoms, or sometimes they usually come with the symptoms itself. The symptoms can be unusual thirst, it can be frequent urination, it can be weight loss, extreme fatigue, irritability, tingling in hand and feet, blurry vision, and changes in appetite patterns. These are the basic symptoms of type 1 diabetes, the 3 Ps which we usually discuss: polyuria, polyphagia, polydipsia, all are there in type 1 diabetic individuals. And the most concerned symptom which the patient comes or their attendants come to us is weight loss. And they're really worried about weight loss. These are the common symptoms which we see. Next slide, please. Yeah. So these are the ADA recommendations regarding the screening. The screening for a pre-symptomatic type 1 diabetes using screening tests that detect autoantibodies to insulin like GAD, islet antigen 2, and zinc transporter 8 is currently recommended in the settings of a research study or can be considered an option for the first-degree family members of a proband with type 1 diabetes. Development of and persistence of multiple islet cell autoantibodies is a risk factor for clinical diabetes and may serve as an indication for intervention in the setting of a clinical trial or a screening for stage 2 type 1 diabetes. So right now, there is no consensus on screening of type 1 diabetic patients. We can always test for the first degree family members, but it's always done for a research purpose rather than for diagnosis. Next slide, please. So what are the investigations which we go through when a patient comes to or rushes to your clinic or walks to your clinic with a report of hyperglycemia? We want the patient's fasting, we want the patient's postprandial, we want to see the HbA1c, we want to see the C-peptide. The C-peptide is a lesser done test. The method has to be very, very accurate. And other antibodies, the GAD, islet cell antigen 2, and zinc transporter. These are some of the antibody tests which need to be done or should be done in the patients. Next slide, please. So what are the antibody testing which we do? It's usually GAD antibody, islet cell antibodies, antibodies to insulin, and cytoplasmic islet cell antibodies. Antibodies in children are GAD is 70 to 80%, IA2 is 60 to 70%, IA insulin antibodies 50 to 70%, and cytoplasmic antibodies 80 to 90%. GAD or IA2 or IA is 95 to 100%. If you get more than 2 antibodies, then the diagnosis is confirmed and we treat the patient for type 1 diabetes. Next slide, please. Just for the sake of knowledge, GAD is the most prevalent and it is the most widely done antibody test in our country. Most of the physicians, they do write for GAD antibody. But in the past, we have seen certain cases of GAD negative work with type 1 diabetes when we do other antibody tests. Now, these are the clinical characteristics of type 1, type 2, and monogenic diabetes in children and adolescents. If you see the genetics part of it, type 1 is polygenic, type 2 is polygenic, but monogenic, of course, by name it's monogenic. Age of onset, 6 months to young adulthood is type 1. Type 2 is usually pubertal or later. Monogenic is often post-pubertal except GCK and NDM, which are the 2 types of various monogenic diabetes which we have. Clinical presentation most often is acute and rapid is type 1. Type 2 is variable from slow, mild, often insidious to severe onset. Monogenic is variable, may be incidental in GCK. Associations autoimmunity, type 1, yes, and type 2 monogenic, both are no. Ketosis is very common in type 1, extremely uncommon in type 2, and monogenic is common in NDM, rare in other forms of monogenic diabetes. Obesity is population frequency. Increased frequency of obesity in type 2. We are seeing rampant cases of type 2 diabetes in young adults these days, especially post-COVID. And after the physical activity has gone down in children, we are seeing more and more cases of young type 2 diabetic patients. Population frequency depends on monogenic diabetes. Acanthosis nigricans, that is one of the most important sign which we should look on all the young obese children who walk to our centers. and it is positive in type 2 diabetes, is negative in both monogenic and type 1. Frequency percentage of all diabetes in young people, usually more than 90% of young diabetic individuals are type 1, less than 10% are type 2, and 1 to 4% are monogenic. Parents with type 2, 2 to 4% in type 1, extremely important is monogenic, where 90% of the siblings or parents would be having diabetes. Next slide, please. So individualization of care is the key to management of type 1 diabetes. And the education part includes the insulin, the various ways to take insulin, monitoring, the physical activity, follow-up of investigations, the emergency care, which is extremely important, least explained factors to the patient. Emergency care can be acute hypoglycemias, it can be a sick day rule, how the patient manages his or her diabetes as a sick day rule. And MNT is again very, very important. Diet needs to be addressed at all levels of management of type 1, type 2, and other diabetes as well. Next slide, please. So we have to create a team. We have to have leaders with type 1 diabetes, the physicians, the primary physicians, the doctors who will be treating them. We need a coach, we need a nutritionist, we need educators, diabetes educators, and counselor is extremely important. But in a resource limited setting, which we might call Jharkhand and the eastern part of the country, where we have very limited resources, we require 3 people. We want a doctor who should treat, we want a diabetes educator cum counselor who can advise the patient regarding various aspects of the disease, and we require a dietitian or nutritionist. These two can also be combined, a 2-person team of a doctor and a nutritionist or a dietitian with qualified degree of a diabetes educator. The 2-person can also make a team and very successfully manage this team. In my center, we have 3 people. We don't have a coach, we don't have an extra counselor, but at my center, we have a diabetes educator, we have a dietitian, and myself. All 3 of us make a team. So whenever a patient with a report of hyperglycemia, a young child comes with his or her parents or guardian, it is duty of all 3 of us to talk to this patient and the attendants for good 20 minutes each. That is our schedule, that is our routine, and we do that. And each of us have to give minimum of 20 minutes and discuss all the aspects of the disease. Why? I'll let you know by other slides. Next slide, please. Next. Yeah. So there is a crisis as diagnosis. As soon as you tell a patient's attendant, especially, or parents, that the patient has diabetes, he or she has type 1 diabetes, and he or she might require insulin for the glycemic control and for their survival, there is a big psychological impact on the patients. They secure a known reality, frightening and foreign world. They are completely confused. I have seen people crying at my center. Every week we have patients. Every week we have patients, attendants. They're crying in front of us. Today being a Sunday, I just go for reporting to my center, and still I could manage to see a type 1 diabetes today. He was a young lad of 14, and her mother started crying. Sir, insulin nahi chahiye. किसी भी तरह से इंसुलिन नहीं चाहिए, इंजेक्शन मेरे बच्चे को नहीं पड़ना चाहिए. You can give me tablets, जितने महंगे हो, जितना पैसा लगे, we are not worried, but insulin नहीं चाहिए. So there is an amount of dejection. They are not ready to accept the fact, and it is our duty as clinicians to talk to those patients and attendants and make them realize about the whole disease process. The normal disease reaction is shock, disbelief, denial, which is very, very important, fear, anxiety, and anger. There is extreme feeling of guilt at times with the parents as well. Next slide, please. So we have to do some amount of hand-holding. On the very first month of the diagnosis of the disease, the patient, the attendant, the entire family requires hand-holding. A new family is vulnerable and traumatized, blood sugars fluctuate, and doses are not yet settled. We have to bust the myth around type 1 diabetes. Emphasis on insulin always. Addressing the possible honeymoon phase. You should always talk to the patient about the honeymoon phase, which might last from 3 weeks to about 3 years at times. Warning against fraud alternative therapies. Perfecting insulin and monitoring techniques. Learning to manage hypoglycemia, and looking out for the comorbidities. and individualization of treatment. Next slide, please. So diagnosis, they have so many questions. Don't, bad, can't, what, how, why me? That these are the most of the patients will ask these questions to you. And you'll have to sit with these patients. You have to counsel these patients. In 20 minutes, I usually manage to see about 3 normal diabetic patients, you can say. But with a type 1 diabetic, I have to devote whole of 20 minutes to that one patient and discuss all these aspects. And if you are able to answer all these questions, next slide, please. If you are able to answer all these questions, there is acceptance on the part of the patient. There is acceptance on the part of the attendants, which is very, very important. Once the attendants, the parents or the guardians, they are sure about the disease, they are convinced, then the whole management process starts from then and there. Next slide, please. So what happens when a doctor advises insulin therapy? Well, they are not ready to take it. No way, not me. Why should I take insulin? My child is too young to take insulin. He's not ready for insulin. Insulin is the last resort for the management of diabetes. This is what the patient's views are usually. So we have to explain it to them. What is type 1 diabetes? Why does it happen to your children? And what are the possible treatment aspects of this disease? Why insulin is essential for their survival. So you'll have to explain all these facts to the patient. And it is you as a clinician, as a doctor, who has to do this job, because they come to your center to meet you, not your paramedical staff. Paramedical staff will come next. Once you are able to explain these things to the patient, then the diabetes educator, and then third, the dietitian, who will have a very important role in managing the patient's diabetes. Next slide, please. So the standard we should strive for, well, as I said, we should have a proper team. Next slide, please. We should have a proper team to manage type 1 diabetes. Unless we have this whole team, will not be able to bring down the patient's blood sugars. Next slide, please. Next one. Next, yeah, go ahead. So patient needs to be educated about insulin. On the last slide, you saw one of the boxes showing schools. Whenever you diagnose a patient with type 1 diabetes, it is your responsibility to sensitize everybody around him. It's not just parents. You have to have a conversation with the school as well. We usually at our center in Ranchi, we always give a handwritten letter, just typed in a computer, of course, to the school's principal and the class teacher regarding the patient's insulin requirement, the patient meal pattern, and amount of glucose which the patient should take, and the regular meals or regular intervals the patient should be taking his or her meals. That is in a written format given to the principal and the teacher of the school. Above that, we also request the school to store some amount of glucose with them, and in case of emergency, if the patient has hypoglycemia, we usually used to give 25% dextrose ampules, which are not readily available these days. We used to give 2 ampules to every kid when they used to come to us, and they used to store those 2 ampules with them. And at the time of emergency, the time of low sugars, those 2 ampules could be utilized. These days, it's not readily available. Now we are getting 100 ml bottles of 25% dextrose and 50% dextrose. Previously, we had 25% ampules. Still, we have it, but it's very scarcely available these days. Next slide, please. So insulin replacement therapy, well, discuss about the technique, discuss about the site, which is very, very important. I have seen patients taking insulin in their calf muscles, and we need to address these issues at the day of diagnosis. The technique, the site, how to store insulin. If you go to the rural India's, the remotest part of the country, they don't have refrigerators. How do they store insulin is again very, very important, and we have to teach them. Gap, the type of insulin, the reaction profile can be explained, and dose adjustment is very, very important. When the patients have hypoglycemia, We have to explain which dose has to be decreased. Well, of course, it can be done over a period of time, but then these are the questions which need to be answered, explain to them how to keep the insulin storage, wash hands, how to roll the insulin bottle when they take it out from the refrigerator, how to draw the correct amount of insulin dose, how to clean the injection site, and how to safely discard the syringe and the needle. Because though the pens are available everywhere these days, we are prescribing pens left and right. But still, if you go to the most remotest part of the country, they are still relying on syringes and needles. And syringes and needles are from RSSDI of India. We are giving it free to all the patients who are not able to afford insulin. At my center, I have 20 patients who have been registered for free insulin. We'll be registering more patients as well. So these patients get free insulin. We are not able to give them pens. We are giving them vials and syringes. So how to discard the syringe, how to draw the insulin, all these techniques have to be explained to the patient. Next slide, please. So this is the adequacy of teaching method. During patient's interaction, instructions are rarely given regarding some of the injection techniques. So this is Titan ITQ results. These topics were discussed with the patients, and we were surprised to see that around 37% of the patients, they did not remember regarding being educated regarding the depth of injection, how deep it should go, the length of needle. 31% never knew about the length of needle. 34% of the individuals who were questioned, they did not know how long to hold a skin fold. 27% did not know the angle of entry of the needle. How long to keep the needle in the skin? 14% could not answer this question. 44% did not know about the mixing and the site and time. And around single use of needle, 16% did not have any idea. So clinicians must emphasize on choice of injection device and related specifications. Next slide, please. So these are the various insulin regimens. Well, we are using premix a lot. You call it premix. I prefer to call it prefix because it's already fixed. We have 30-70 or 50-50 or 25-75. It's already fixed, and we cannot change it by any matter of chance. So these insulins should not be used in type 1 diabetics, especially initially should not be used because it will be extremely difficult to control the patient's blood sugar with these prefixed doses, and especially in a young child whose eating pattern is not definite, who can ask for meal any time of the day. Premix insulin is not at all recommended. Rather than that, we should go for basal bolus. Number of shots do go up, yes. We require 3 to 4 shots, minimum 4 shots if you are going in a physiological comparing manner. If you compare it to physiological of the insulin secretion of a body, the basal bolus is the most useful and one of the best regimens which should be used in our patients. We give 1 shot of basal insulin and 3 shots of prandial insulin, and we can control the patient's blood sugar very easily. Next slide, please. So monitoring of blood glucose, why is very important? It's very simple. It is the cornerstone of glycemic management type 1 diabetes. It's important for optimum glycemic control and thereby preventing long-term and short-term diabetes complications of diabetes. Engage, educate, and empower the patient, thereby reinforcing the healthful behavior. Integrate with other areas of diabetes self-management like carb counting, insulin dosing, and exercise. It helps individualize self-care in diabetes. Next slide, please. So the patient should be encouraged for SMBG. SMBG is extremely important. Blood glucose monitoring, SMBG is must. We can go for CGM, we can go for AGP, we can go for HbA1c and uric ketone monitoring on sick days, or high blood sugar is also recommended. Next slide, please. So SMBG, well, technique is very, very important. How to store the strips, again, very important. Record keeping, log books, electronic, we can do it. Graphs to see the trends. We know 7-point profile by AD is again very important. Pre and post, before breakfast, pre and post breakfast, pre and post lunch, pre and post dinner. And we can check a sugar at 3 a.m. as well. So this 7-point profile by ADA is again very, very important and should be adhered to. Next slide, please. I'll be showing a logbook to you. Next one, please. So this is the monitoring and logging profile. If you see monitoring and the logging profile. So this is the basic profile which we give at our center. It is very difficult to ask the patient to check 7 sugars on 7 days a week. That's extremely difficult. So on first 2 days of the week, we ask the patient to check Monday and Tuesday, fasting and post-breakfast. On Wednesdays, fasting should be checked every day. On Wednesdays, he can check pre-lunch and post-lunch, Thursday pre-lunch and post-lunch, Saturday pre-dinner and post-dinner, and Fridays we ask to check all the 7 sugars. This is easier to follow, less number of pricks, less number of strips are required, and in a financially constrained settings, this is the best way we can adhere to, and we can stick to the sugars and the glycemic controls. Next slide, please. So CGMS, try at least once. It is easily available these days. It's a must wherever possible. Continuous use and learning to interpret real time. Our center, we have been doing CGMS since last about 10 to 11 years. We started with Medtronic. We are still doing Medtronic, and we are also doing LibrePro from Abbott. We empower the patient with type 1 diabetes to be able to take dosing decisions. If not affordable, try to use once in 3 months to establish patterns for better understanding of treatment. It gives amazing insight to fine tuning to the care. It's a big eye opener for the user regarding the effect of various food and activities. It's a boon for a person who needs flexibility in lifestyle. And CGMS is the only device which can catch the glucose variability. The highs and lows of blood sugar can be seen only with CGMS. I had a patient who had extremely good HbA1c control. It was 6.4, and it's very rarely to find 6.4 in a patient with type 1 diabetes. We usually target 8 because less than 7 is extremely difficult. So that guy used to have his breakfast at home, and he used to have a high post-lunch sugars every day. So we are really worried कि high post-lunch sugar कैसे होता? What is the reason for high post-lunch sugar? And he could not find any fault with his lifestyle. So we put a CGMS machine to him, and we gave him a diet chart. So diet chart means he was supposed to write whatever he was eating every day. And a very peculiar thing we noticed in his diet chart was every day around 11:30 p.m. he had a milk break in his school. They call it milk break in the school. And he used to have a biryani from a local shop just outside his school. So he was having that biryani every day. So we could catch that biryani was one of the reasons for post-lunch hyperglycemia. He used to have his lunch at 1 p.m. as well. So we had to replace that biryani with a steamed rice or something similar, and then we can very easily adjust his blood sugars. So sometimes this glucose variability part will always be addressed. Without the CGMS, you'll not be able to see the glucose availability part at all. Next slide, please. So nutrition, again, myths regarding nutrition, it was discussed by Dr. Shah in the beginning. Carbohydrate counting is extremely important, customized as per personal need and culture in between snacks. Bedtime snacks, again important if the patient is bound to go for hypoglycemias or has recurrent hypoglycemias. Religious diet for feast and fast, again important. And our recent governor is from Tamil Nadu, and he had 2 visitors last week. And out of those 2 visitors, one of them had hypoglycemia. He happened to visit my center. And he had a very different meal pattern from what we see in Jharkhand and Bihar side. So we had to adjust his insulin as per his meal behavior. So India is a diverse country, and every state has their own staple diets. And some of the states have staple diet, rice as their staple diet. You cannot take off rice from their plate. It is very, very rude, and it's not acceptable to the patient as well. So you have to be very, very careful regarding the patient's dietary pattern, and we can discuss these dietary patterns with the patient and adjust his blood sugars. Vitamin supplements, well, again, the patients might require vitamin supplement, and we can always discuss. At times, test is vitamin D and B12, which is again on the lower side in most of our patients. Next slide, please. So meal planning is, again, as I discussed, it's not very tough. Next slide. Physical activity should be encouraged in all our type 1 diabetic individuals. Appropriate intensity of physical activity should be explained to them. Role of SMBG and extra snacks. If the child is going for some extra physical activity, intense physical activity, we should monitor his or her sugars, because the sugars bound to go down after intense physical activity. So insulin dose adjustment at times are required. Next slide, please. Yeah, so just 2, 3 slides again. Hypoglycemia, very important, low blood sugar less than 70 is always a concern for us. It is caused by too much insulin or too much diabetes medication, or without diabetes, it can be because of eating less or exercising more than usual. Some medications, alcohol, underlying conditions, reactive hypoglycemia is very, very important. At times in type 1 diabetic individual, if the patient misses his meal or her meal or take less amount of carbohydrate in the meal, the patient is bound to go for hypoglycemia. What are the symptoms of hypo? Hunger, fatigue, shaking, sweating, pale skin, headache, and dizziness. Extremely common. And 15-15 rule should be applied. You should test the blood sugar, give them 15 grams of fast-acting carbohydrate, wait for 15 minutes, check again. If the sugar is low, repeat the process. If the sugar is more than 70, then we should stop. We should not over-treat hypoglycemia. It's very, very important. Usually when a patient has hypoglycemia, we start giving them sweets, we start giving them chocolates, we start giving them and chocolates, sweets, sugars, and sugars, they jump to 400 or 500, and then we might require extra amount of insulin. Next slide, please. Sick day rule, again, very important. Check blood sugar, urine croutons on sick days. Plenty of fluid should be given. We require additional insulin dose. We require additional insulin dose to be emphasized upon. The patients usually will stop their insulin on sick days. And we have to be very, very careful and advise this patient to stick to their insulin dose, and at times might require a higher dose of insulin. During gastroenteritis or acute gastroenteritis, when the patient is losing a lot of electrolytes and passing watery stools, well, the sugars might go down. Be a little careful, keep checking, but the insulin should be used. It should not be skipped. Frequent SMBG, treat the precipitating cause, and hospitalization whenever is required. Next slide, please. Education and its tool, well, we have discussed this, the basic education, comprehensive, advanced. You should explain the patient regarding the diabetes. What is diabetes? How insulin should be used? What are the insulin techniques? What are the comorbidities of diabetes? And what are the food exchange programs, basic carb poundings, which you can do, and SMBG. These are the basic things which we should always teach our patients. Next slide, please. So peer group activity, well, introduce new people with type 1 diabetes to experienced champions. Leaders with type 1 diabetes make motivational educators, and that makes them realize that they're not alone. They can do it if others can do it. Sharing and learning is extremely important. And keeping this in view, we had a very good diabetes conclave in Ranchi about 3 months back, where we gathered 40 type 1 diabetic children with their guardians. So we were about 120 of us with about 6 doctors, and Dr. Jagnany was part of it. And we had a very good interactive sessions with the children. We had a diabetic breakfast. We did all the possible tests of the children on that day. And then we had diabetic lunch. And in between, we had some physical. And then we had a good conversation with the children and their parents. And we allowed the children to interact amongst themselves as well. And that gives us a very good results, encourages these children. Positive vibes are created, and it boosts their confidence a lot. Next slide, please. So a child with diabetes can lead a normal life. With a proper treatment, children with diabetes can grow up to be productive, fertile, and long-lived adults. Regular insulin, proper monitoring, and balanced diet and exercise are 4 pillars for living healthy and normal life with diabetes. Next slide, please. Next, please. Yeah, these are the champions of type 1 diabetes. We all know Nick Jonas, Kamal Hassan, Wasim Akram, Brett Michaels, and Olympic swimmer Gary Hall Jr. All of them had type 1 diabetes. They are still on insulin and leading a very normal life and giving us hope to children around the world. Next slide, please. So true, it is a fight, but there is a pleasure in the struggle. Victory comes to the courageous. Look upon the type 1 diabetic as charioteer, and chariot is drawn by 3 steeds, namely diet, exercise, and insulin. It takes skill to ride 1 horse, intelligence to manage 2, but a very good teamster who can get all 3 together. It was said by Jocelyn in 1933. So diet, exercise, and insulin will help all your type 1 diabetics to manage their blood sugars and live a healthy, good quality life and manage their life very, very well. Next slide, please. Right. Thank you so much for your patient hearing.